moderate successes using this biopsychosocial way of looking at the world in patients with chronic pain. I won't go through all of this. This is in your handout, but it's a nice general comparison between the biomedical and the biopsychosocial way of looking at the world. Good morning. The biomedical perspective looks for a cause. Oh, it's an infection. Oh, it's a ligamentous sprain. It looks for a very specific cause. The biopsychosocial way of looking at the world recognizes that there are multiple causes, biologically, but also psychologically, emotionally, cognitively, etc. Biomedical looks for a disease process. Biopsychosocial looks at the disease and the suffering or the illness behaviors that go with it, because they go together. Biomedical looks more at anatomy and biomechanics. Biopsychosocial acknowledges the importance between anatomy and mechanics, but also engages in the brain as a piece of that process. So one's more of a disease focus, one is probably more of a preventative or a health focus. With regard to the biomedical, often it's a passive process. I'm going to the doctor to give me an injection, give me a pill, do a surgery. The biopsychosocial is much more engaging, more active, much more self-management oriented. More active coper versus passive coper, you could say. All right. The curative therapies for biopsychosocial, as I mentioned, are those individual treat the cause, surgery, medication, a manipulation, a little quick little manip, whatever it might be. There's much more of a multidisciplinary way of looking at the world when it comes to biopsychosocial. There's more harmfulness perceived with active movement biomedically. If it hurts, stop. If it hurts, don't do it. Biopsychosocial said movement is the key. Keeping yourself movement is the healthy part of it all. Okay? So there's a much less harmfulness perceived as being danger in the biopsychosocial. In fact, movement, as you'll see as we go along today and tomorrow, is the key to many of our patients regaining their function and dampening down their sensitivity. We would like you to think that the biopsychosocial approach is the new rule of thumb for pain management. For all patients, as a matter of fact, the heuristic, kind of an intuitive obviousness to the problem, the one that makes the most sense, if you will. The literature supports that, as do a lot of things. We have many, many, many elements that support a different way of challenging yourself to understand the patient's complaints using a biopsychosocial approach. Melzack and Wall's textbook on pain. Melzack and Wall, the guys who wrote the gate theory, said the gate theory doesn't work anymore. You've got to move beyond it. There are a number of randomized controlled trials. There are some systematic reviews, as well as Delphi studies from expert opinions from physical therapists and physicians. It is backed by the International Association for the Study of Pain, by the World Health Organization, who's engaged in it. A biopsychosocial model is now starting to be utilized in the education of PTs and MDs throughout the world. OTs have had a biopsychosocial way of looking at the world as part of their educational model for a really long time. Okay? It needs to become a deeper part of our education if we're going to start to change the way we practice and start to change the way that our patients see the world. Right now, however, we are getting lots of backing from a number of organizations saying you need to move in this direction. The biopsychosocial way of looking at things, in a lot of ways, could also be looked at as part of the body-mind connection, the psychoneuroimmunology, if you will, between the brain and the body with regard to the neuroimmune and neuroendocrine abilities to cross those boundaries and create health or misbehaviors. Questions so far? Okay, nobody's falling asleep. It's pretty early. I might fall asleep before you guys, as a matter of fact. So one of the things that is changing, that is probably an important shift for you, that is a huge shift in neuroscience, is to recognize that we rarely treat anatomy. Even though we're taught to examine for anatomy, oh, it's a bicep strain, oh, it's the medial collateral ligament, oh, it's an L5 disc. What we end up treating is the processes that create the behavioral responses, the pain responses, because of a change in anatomy. We treat processes like inflammation or ischemia or the degenerative process that relates to ischemia and inflammation. Because if I calm down the inflammation around that disc or around that medial collateral ligament or around that bicep strain, and I do an MRI, the disc is still there, the medial collateral ligament is still strained, the biceps is still torn. Did I treat the tissue or the anatomy, or did I treat the process, inflammation usually, to dampen down the nociceptive feedback to the system that now says, hey, I'm okay again, I can move and I don't hurt? That's a big deal. In fact, most of the literature now is recognizing that it's a neuroimmune response that we end up dealing with. The immune system gets engaged in the reaction to the injury and now becomes an inflammatory trigger that stimulates sensitivity in the system. And by dampening down the immune response and dampening down the inflammation, the process, that's huge. Dampening down the process, now we can have an effect on the individual and their abilities, their comfort, their function, whatever. So I first get you to recognize that we probably don't treat anatomy, we treat the processes, and usually it's one of these two. It always leads to inflammation, but it could start with ischemia. So we also have the biomechanics. Is that enough, really? Enough of an explanation? Because if I know anatomy and biomechanics, that's what my professor said, I should be able to treat almost anything. I can examine you, glide it, stretch it, whatever it is. That usually isn't enough. If you're really a manual therapist and you say, well, I've got anatomy and mechanics and tissue pathology, which is kind of the world or the realm of manual therapy, that's kind of where it stops. That would be about as deep biomedically as it gets. It's probably not enough. And so there's been a need to develop broader paradigms that engage the nervous system, neuroscience paradigms. Two that we're going to talk about today, tomorrow, and Monday and Tuesday are going to be the pain mechanisms model, what we call the mature organism model, and a lot about the neuromatrix, Patrick Wall neuromatrix model of representation. That's a big deal. Let's look at them. The pain mechanisms model is a very, very, very useful schematic. I need you to understand this. And we'll go over it again and again in different ways. This is a really nice schematic developed by a physical therapist, Louis Gifford. He just passed away a few weeks ago. He was a UK-based pain science physical therapist. He used to teach with David. And in the late 90s, he developed this sub-paradigm as a part of the biopsychosocial way of helping us understand where our patients are, engaging the brain. And in essence, he helped us recognize that there's a body, and that means that there's a tissue injury that occurred somewhere in the body, and it usually occurs in some type of an environment or a context. The injury occurred within some realm of the individual's life. We'll talk about that in a minute. That injury is input, danger signals from the body, not pain signals, but danger signals, nociceptors, are input into the spinal cord and into the brain where they're processed. And the brain decides, based on those danger signals and its processing, what to do about it, and it's expressed as an output into the environment to protect me. That's about as simple as it gets, but let's talk about it in a lot more detail. So, mature organism model is input, processing, and output. What we see is the output expression. When a patient comes to our clinic, or when you go home at night and see your young son, or your husband or your wife, their behaviors, their movements, their actions, their attitudes are all output expressions of who they are at that given moment based on their life. Like right now, you guys are all hanging out giving me a posture and a movement that tells me a little bit more about you, or that I make up, because that's your output at this moment. Okay? Some of you look at me and engage, and others are looking down and then they're looking up because now they know I'm looking at, whatever it might be. Those are just behaviors. So that's what we see first. We'll talk about that in a minute. Let's talk about the inputs, though. And we'll talk about patients that have some type of an injury to their tissue. That injury occurs in an environment. And the literature would say that it's the context of the injury, or the environment within which the injury occurs, that has a significant effect on how that injury is interpreted or processed, and how it's expressed as an output. Example: I'm walking down the street, I sprained my ankle and there's a bus barreling down at me. Sprained my ankle. Here comes a bus. What does my brain do? I don't have an ankle. I got to get out of the way. Tissue injury, but the environment or the context within which that injury occurred had made me adapt, and my brain says, nope, not right now. You got other things that are more important. Okay. If I sprain my ankle, same kind of an ankle sprain, I'll sprain my ankle, but I do it at work in front of my boss. Okay? Totally. Oh my God, that's bad. Oh, I got to go home. This is really bad. Fair enough? It's just an example of how the same kind of an injury can occur in a different environment and create a totally different reaction as an expression of that injury. So the context within which an injury occurs, first of all, is super important. If you sprain your ankle or whatever it might be, and you're taking a walk with your 5-year-old son, and you don't want him to see that, and you're like, oh, Dad, what's wrong? Oh, I'm okay, no problem. Everything's good. There's not a problem. Because the context made me behave differently. Injuries that occur in a stressful environment are 8 times more likely to move to chronic pain. Makes sense. If I'm stressed, then that interpretation here has a lot more to do with what I think than if I'm not stressed and happy and life is good. So input problems have everything to do with context or environment. That input, those danger signals, no matter what's going on, cross over into the central nervous system, into the spinal cord where the processing starts, and then move up into the brain where further processing occurs. Processing could also be termed scrutinized, because the brain's looking really hard at that issue. But that depends on who you are. It's different than who I am. The processing piece is because of who you are, what your beliefs are, what your mom and dad told you, what your memories are of that particular problem, what your faith might be. Whatever it is that makes up who you are is how that injury is processed. That's why no shoulder injury is the same between you and me and your neighbor. We're all 3 different individuals, and therefore that injury is going to be processed. Assumptions are going to be made that are totally different between the 3 of us. Input, processing, and then the output expression. The brain decides whether or not